Good evening, and welcome to the Second District Health and Wellness webinar. I am Dr. Keith Boykin, a retired pediatrician and trained internist, and I'll be your moderator for the evening. I hope everyone's had a wonderful Thanksgiving. I know I did, and are ready to get some more information about what we're doing. But first, let me just say a few things, that the opinions and ideas presented here are those of the people that give them, individual brothers and or presenters, and do not represent the Omega Psi Phi Fraternity Incorporated. Tonight we have a special focus for you guys. We have a topic that everybody's heard about and probably don't know really a whole lot about it, or think they know a lot about it. So we're gonna do a special thing tonight for you. But before we get into that, I'm going to introduce my brothers who are here with me this evening, and our chairman. I'll introduce him first, and then I'll follow the rest of the brothers. So with that, I'm going to have you turn it over to Dr. Phillips. Dr. Phillips, you come on and give us your opening statements, please.
Good evening, 78. How you doing, my brother? Rough day today. I had to hustle home from the office, got in just a slick of time, just got in. But I'm glad to be here because, again, you know, as we've been doing every month, continuing to talk about preventive health issues that, unfortunately, when they're not addressed in a preventive way, they cost us a whole lot more as far as how it impacts us physically, and it can impact our lives. One of the conditions that can be extremely frustrating is the condition called epilepsy. And with this month being Epilepsy Awareness Month, we wanted to talk about a condition that can be very difficult to identify, but also extremely difficult to find the right therapy. So I am excited for our conversation tonight. We've got some additional features to our program tonight that I think are going to be extremely interesting to our audience. So again, bro, I'm glad to be here, and I'm glad to talk, and I'm glad to be here with you and the rest of the brothers.
Thank you, Dr. Phillips. Okay, let's have Dr. Isabell, 95. Brother Dr. Isabell, will you give us your opening statement, please?
Good evening. Once again, happy to be here. Board certified internal medicine, primary care, as well as patient care and HIV primary care. Epilepsy Awareness Month. At times, a lot of patients or people aren't aware the signs or sight of a seizure or a stigma with it. And I like to share my side regarding information on epilepsy. Thank you.
Thank you, Dr. Isabell. And last but not least, we have Brother 96, Brother Dr. Christopher Plummer. Would you come on and give us your opening statement, please?
Hi, good evening, everybody. My name is Dr. Christopher Plummer. I'm board certified in OBGYN, and I specialize in maternal fetal medicine, high-risk pregnancy. It's great, again, to be with the brothers and talking about certain situations that affect our community. I just want to, for people to be aware, if you do happen to have seizure disorder or epilepsy, if it's well controlled, pregnancy usually can be very uncomplicated, but we'll dive in that a little bit more in our conversation today.
Thank you so much, Dr. Plummer. So as I think Dr. Isabell and Dr. Phillips said, this is National Epilepsy Awareness Month, or NEAM, as the Epilepsy Society calls it. And so they're launching a campaign to reduce the stigma associated with epilepsy, because I'm sure you know someone that probably has a seizure disorder, epilepsy, and somebody in the family might say they have fits. So that's the thing we don't want the people to understand. I mean, we want people to understand that they're not having fits. It's a medical condition, neurological disorder, and or an associated with another disorder. So first we got to talk about what is the difference between a seizure and epilepsy. A lot of this defined it kind of set the tone here for us. First of all, a seizure is a single isolated event, whereas epilepsy is a continuum or repetition of seizures. So that's what the difference is between epilepsy, and seizure and epilepsy. So I want people to understand that we may use the terms interchangeably tonight, but epilepsy is a condition of continued seizure. So I just want you to understand that. So first of all, seizures come in all sizes and shapes, so and colors and magnitudes, if you will. So I'm just gonna have Dr. Phillips give his experience of what he's seen over the years with seizure and epilepsy.
Well, the first thing I would say is as we look at how we define seizures, one of the other aspects of epilepsy, as far as the definition, is the occurrence of 2 or more seizures that occur over 24 hours apart. Now, again, as you mentioned, a seizure is a presentation or a symptom. It does not necessarily, mean that a person has a chronic lifelong condition. I'll share a personal story. I can remember with my youngest son, I was up late and he was in bed and I went laid next to him. He was 2 years old at the time. And what happened was he woke me up tapping. He was tapping me and I didn't know what it was. I woke up, he was in the midst of a full-blown seizure. Now, the backstory was leading up to that, he was having fevers and wasn't feeling well. Ended up, he was diagnosed after we had taken him to the hospital with a febrile seizure, which, as you mentioned, there can be conditions that can contribute to a person having a seizure episode. But that does not mean that you have to have a lifelong condition. For example, my son, after that one seizure, which was related to his ear infection, once the ear infection was treated, he never had a problem with seizures ever again. But again, it's very important to understand that because, number one, if you are having recurrent seizures, there are medications that can be utilized to treat that. And that's with a person who might have the condition of epilepsy. But if it's the symptom or condition of one having a seizure, that needs to be addressed as far as finding out what contributed to it. In my case, it was a fever related to an infection. In other situations, I've seen some of my diabetic patients that have been taken to the hospital with seizure-like activity because they had low blood sugar. So there are a variety of things that can contribute and cause this issue. So I think that this is an important conversation because this is one of those situations that people get caught up in a gray area. I went to the doctor, he says I don't have epilepsy, but what do? I'm not sure if I want to take medicine, but what can I do? The seizures don't occur that frequently. And that's another, aspect of it. And I think the biggest thing that I would also like to communicate is what happens when a person has a seizure or has epilepsy, their brain gets a storm or flooded with electrical impulses. And these electrical impulses can result in the seizure activity. Now, the reason I mention this specifically, because as we all know, the brain accomplishes and takes care of multiple functions of ours. So wherever the electrical storm is could also dictate the type of symptoms that would be part of the seizure that a person might have. You have individuals that don't have any jerky movements and just stare into space. That is a certain type of seizure as well. But again, I'll yield to my other colleagues, but seizures are something that is extremely important, and I'm glad we're having this conversation.
Thank you, Dr. Phillips. You brought up two important points I want to stress them before I go to our next brother here. One, you had a condition associated causing your son's fever called febrile seizures. They can be simple or it can be complex febrile seizures. And it's most frightening. That's one of the probably most frightening types of things I've experienced in my years of pediatrics. A child has a fever, and then the parents don't know what to do, or they're frightened, and they don't know how to take care of it. They don't know how to manage it when they come home. And the biggest fear is, will this lead to a lifelong disorder? And you've so eloquently said it didn't in your son's case. Now, some of these kids can have a focus, that was unknown and maybe turned on later, and still have febrile seizures. A seizure could be something simple for a kid might get, wrapped in the head. He might fall out and have tonic-like movements, which is seizure-like, might not necessarily be a seizure. So those important things that we talk about tonight, I want our guests to understand that these are things that may be another medical condition, or they may be signs of an impending lifelong problem. So I know you see a variety of patients, Dr. Isabell. I mean, you take care of the HIV people as well. So I'm sure you've seen all kinds of different types of seizures in your adult practice. Well, tell us a little bit about your experience with it.
My experience with seizures, so I start in the office. Sometimes A patient may not know that they have a seizure. They may come in, they may have what we call syncope episode. They may pass out, or they had uncontrolled movement, or they have a loss of brief memory, or they may wake up and they notice they have a bloody tongue, or they may wet the bed, or it's noticed by some other family member. So they come in, or they're not feeling well for a little bit. So then they come to the office. We do a history regarding, have them try to the best that they can to describe their symptoms, or family member, or if there's any family history is always important, of any seizure, diabetes, cancers, or are they on any medications? Have they also, some people may get offended, but you always have to ask, do they drink alcohol, or have they any illicit drug use? Because those are some of the we call provoked seizures. Non-provoked epileptic is a serious thing where somebody more than likely down the road cannot drive. But if we find a provoked seizure, doesn't mean necessarily that they can, depending on what state they're in, they can't drive for 6 months to a year. So when I say provoked seizures, or something that can lower the threshold, we're talking about alcohol, we're talking about illicit drugs like cocaine, opioid withdrawal, or sometimes benzo withdrawal, dehydration, or being sick, infection like HIV. Sometimes that you can get meningitis, you can get other types of brain infection, you can get a parasite, things that could cause seizure, or sometimes, unfortunately, it could be a cancer. So these are some of the provoked things. So then you would want to do like a workup. You would do blood work to make sure things like they're not a diabetic, or they didn't have like some type of hypoglycemic episode. You would want to do your physical exam. You would do a CAT scan of the brain or MRI of the brain to make sure there's no pathology like a mass or a tumor, or that they didn't have any stroke, because a lot of age 35 and up, sometimes it could be a high risk if somebody could have a stroke, and that can also cause a seizure. Or if they have some type of artery or vein malformation, that can also cause a seizure. So those are the things that we look for. Then we get what we call an EEG. It checks the waves, electrical waves of the brain, to see if there's any spikes or any evidence, signs of seizure activity. There's even more like focal EEG or special MRIs or focus MRIs that can pinpoint seizures also. So these are some of the things we do for a workup of seizures. If somebody has one seizure, doesn't necessarily mean that you would need to be on medication. But unfortunately, if you have multiple, then there's maybe treatments that out there, medications, and there's other treatments also. Thank you.
Thank you, Dr. Thank you, Doctor. You raise a very important point in the workup, because once you have the workup done, then you got to figure out the right person to direct them to for the treatment and management of that particular disease. But then we have a special case, though. I mean, what do we have like during pregnancy, Dr. Plummer? We have women that are pregnant. You have a twofold situation here. You have to take care of the mother, and you have to worry about the immediate period when you call me and say, Dr. Boykin, I got a 40 month, full-term baby here is having seizures. What's going on? And you tell me, well, the mother has seizures. So that's a different approach for me. But talk about seizures in pregnancy and seizures in gynecology and period, if you will.
All right. Well, the most important thing I want to emphasize is when a woman is pregnant and she has a seizure, the most important thing is to go to a hospital and get evaluated, because the most common seizure during pregnancy is what we call an eclamptic seizure. And eclampsia is seen when a woman has elevated blood pressure and she might not even notice it, and maybe headache. But on top of that, when you have eclampsia, you have a seizure, and that can cause an increased risk for the mother to die and also the baby to die too. So that has to be taken very seriously and get evaluated in the hospital, because the only cure for preeclampsia is delivery. But if it's not recognized early, mother can lose her life, and also the baby can also lose her life. Now, if a mother has a history of epilepsy and is on medication, generally, most of the newer medications that she can stay on, usually Keppra or Lamictal, are usually the medications that they can stay on during pregnancy. It's well tolerated in pregnancy. It doesn't increase the risk of malformations. Then that one, if they're very well controlled on that, then usually they'll have a very successful pregnancy without any issues. Also, those medications can also be used when you're not pregnant and on birth control, because some of the older seizure medications, when they used to take them, we used to reduce the efficacy of birth control, and they used to become pregnant. And the older medications like phenytoin and carbamazepine can cause fetal malformations. So if you are pregnant and you have epilepsy and you're considering about getting pregnant, one, consult an OBGYN or maternal fetal medicine doctor. Two, have them change the medication to at least one, try to use one medication if possible, but usually the ones that are usually more well tolerated in pregnancy.
Thank you, Dr. Dr. Phillips, did you have something you wanted to add to that? Did I see you message me?
No. What I want, just to add on to the conversation, I think Dr. Isabell and Dr. Plummer have touched on it, is how you have to move a little differently if you do have epilepsy or a seizure disorder. Some activities, driving, as he was stated, there's some legal rules in place to put limits on that. So you want to consult that. But there are also some other activities, again, going swimming by yourself, scuba diving, things like that. You got to be mindful of. I have a patient who has epilepsy, and she is not allowed to cook in her kitchen because of concern that she could have an episode while she's cooking, and that could lead to her injuring herself, destroying her home, etc. So again, I think I'm going to emphasize how important it is, if this is the case, touching with your doctor so you can find out, what type of activities are safe for you to do and what type of activities that you need to avoid or take precautions with.
Thank you. Yeah, that's very, very important, because in my days when I practiced internal medicine and pediatrics, I unfortunately had a mother that I took care of who had a seizure disorder, and Dr. Plummer alluded to this a little bit in his part. He talked about one of the medications she was on was called Dilantin, and then we have something in pediatrics called fetal hydantoin syndrome. They have different type of anomalies. This baby ended up what we had to call a 2-vessel cord. Didn't have the full 3-vessel cord. So that was the first infestation, and she had her nails were gone. But the unfortunate part of it was that the mother developed something called HELP syndrome. I won't get into that here because it's too complex for this particular audience here. But I helped manage her HELP syndrome, and I took care of the baby because the baby was born around 37, 38 weeks. I believe it was Dr. Plummer. But anyway, the unfortunate situation, this mother Dr. Phil talked about consequences. the baby was a little bit older. I don't remember how old the baby was, but the mother was taking a bath and unfortunately had a seizure during the bath and drowned in the bathtub. So it's something that you have to be aware of. You know, there are consequences for it. For example, in Virginia, Dr. Phillips and Dr. Isabell I mentioned this. If you have a seizure, and it's always hard for me because I always had teenagers who want to get their learner's permit to drive, you know, and they have a seizure. So what is the rules on driving if you have epilepsy? So the state of Virginia is kind of not weird, but they have a kind of a tiered approach to it. First of all, you cannot drive for 6 months from your last episode, your last seizure. If you have no seizure from 6 months from your first run to the next episode, nothing's going on. If you have, in other words, if it's been 6 months since you had your first seizure, then you're allowed to be reevaluated by a doctor, or it's called you have to have a medical statement from a physician saying that you're okay to drive. Now, sometimes this is managed on seizure, sometimes it's managed without. I mean, managed on medication, sometimes it's not. So people might be on medications, and then they may have what's called a breakthrough seizure. In Virginia, if you have a breakthrough seizure, you have to go for another 3 months without driving, and then be reevaluated by a neurologist at this time. It requires a neurologist statement to say you can go back to driving at that particular time. So I've had students, I fill out these forms many times in Virginia for can they drive, what is its consequences and things like that. But I always consulted a neurologist because the neurologist can tell me, based on their observation, based on their evaluation of the patient, is this going to be a complex problem? Is this going to be a long-term problem, or what? So those are some of the things that you have limitations from a seizure disorder. Now, you know, the younger the child is, there may be all different types of complex seizures. We have what's called focal seizures in pediatrics, sometimes in adults too. We may be talking about a particular type of focal seizure tonight. And then we have the generalized, you know, shaking that we call tonic-clonic activity, where you generalize shake and things like that. And then we have this situation where the teacher calls me and say, you know, I think you need to talk to this mother. This kid he'd be in class and talking, all of a sudden he just goes mute for a few seconds, or he just go staring, absence seizure. So that seizure is not associated with any shaking, but just kind of a detachment from where they are. Not like narcolepsy. That's falling out from lack of sleep. So it's important to understand the difference between those two things. So the consequences are that. But I think the biggest problem we're having is that what types of people are having seizures, who are having more seizures than others, and how do we get them to care? I think that's the biggest part about it, how we get them to care. I think you wanted to add something to that, Dr. Isabell? I saw you flash me on your mic there.
Yes. I just want to just go a little bit more detail in the different types of seizures, not that detail, but just how can my question to some patients or the people out there, they may want to know, well, how can I recognize if I'm having a seizure or if someone else is having a seizure? As you mentioned, focal is a part of the brain. For example, say part of the temporal lobe seizures, which your temple is on the side. And this is a lobe process of emotion, and which may also it plays a role in short-term memory. People who have these seizures often may experience an aura, which may include sudden emotion changes, things like even fear or joy, or even problems with certain things like swallowing. So that could be a possible temporal seizure. Then you have your frontal lobe seizure, which is part of the brain that controls movement. So sometimes a patient may have movement, their arm flexing their arms, or uncontrolled movements, or repetitive movements, or rocking. They can move their heads in the frontal lobe. Occipital lobe, which seizure, which is your occipital lobe, which is in the back of your head of the brain. This could affect your vision, and also somebody may see hallucination. So this hallucination, where stigmas, people think, oh, this person must be crazy, not knowing that back then maybe this person was having a seizure. So that's occipital. And then we talk about the more general different types of seizures, where one we call a tonic, where you lose movement, a sudden loss of control, and where you can, fall to the ground. And there's different other types, but that's, I just want to mention the different parts, and there's many more different types of seizures out there. Some may affect the whole body, some just certain parts, arms, limbs.
I think Dr. Isabell touches on something really important, because I have seen patients who have had absence or more non-traditional presentations of epilepsy or seizures, and they have been dealing with this for years because they weren't sure what to do. So again, God bless Dr. Isabell, letting everybody know the variety of symptoms that can all be considered epilepsy, that can all be considered a seizure. It doesn't always, because I think we are stigmatized, stereotyped, influenced to think a seizure is just this. Mm-hmm. And there's so many other ways. And unfortunately, like I said, I had a patient who had absence seizures for about 5 or 6 years and failed in school, just a whole lot of frustration because him nor his loved ones really thought that this was a seizure issue.
Yeah, that's so important. Go ahead, Dr. Isabell.
And to add to that, sometimes unfortunately, you could get a misdiagnosis of ADD and on medications like Ritalin, Adderall, but sometimes high doses of those meds can also induce seizures.
Absolutely. I was going to say that we talked a lot about different types of seizures, epilepsy, and things like that. But we need to talk a little bit for a brief second about management. The first thing I want to say, the misconception that do not stick anything in someone's mouth when they're having a seizure. Do not do that. And the misconception got out there, put something in their mouth, keep them from biting their tongue. No, don't do that. What you want to do is make sure they cannot hurt themselves. You gently help them to the ground or whatever, but do not try to put anything in their mouth. If you try to put your finger in their mouth, you're probably likely to get it bitten off. So do not do that. So there are other things to talk about in management, but I want to bring that point out first. So, but I know, Dr. Plummer, you probably have women with seizures that's not related to preeclampsia, and it's just a difficult management for you because you got to worry about how the medication can affect the pregnancy and how's the medication going to affect the baby. So when they come out to see me, that I got a pretty good baby. So you want to add anything to the management and from your end about that?
Generally, if women have well-controlled epilepsy and are on a medication, usually the newer generation of medications are usually well tolerated in pregnancy, they usually will have a very successful outcome. Now, one of the things is as the pregnancy gets bigger and more advanced, sometimes the level of the medication that you do also lowers too. So generally, we also have to follow the serum levels just to make sure you're at the right level for that. So sometimes their levels drop, and some of the women, they end up coming in with a seizure. And then there's a differentiation of the two, because them having a breakthrough seizure is quite different than a clamtic seizure, because in a clamtic seizure, the only cure for that is delivery of the baby. And it depends if they're very premature, you don't really want to deliver the baby if the patient just has a breakthrough seizure. So that's when, neurology gets involved. We do an EEG, we check the blood pressure, we just make sure everything else is fine. Sometimes also we might do a CT scan of the brain or MRI of the brain, because sometimes a bleed or space occupying tumor can cause a breakthrough seizure or even a new onset seizure. So that is also sometimes we also have to take in mind, and not every pregnant woman that has a seizure is an eclamptic seizure.
Thank you. So we talk about some of the limitations of having a seizure, or epilepsy, I should say. We talked about some of the limitations, but what about breastfeeding? What about breastfeeding and seizures ordered medications? Can you comment on that, Dr. Plummer?
Against the newer ones that I'm more familiar with, like heparin, Lamictal, Those are the most common ones. They're compatible with breastfeeding. It's not an issue. And also, it doesn't really cause an increase in fetal malformations as we used to see back with the older medications.
Right.
So
Right.
that such as spina bifida or growth restriction and things like that we used to see with the older medications. These newer ones are more well tolerated, and usually women are compatible with breastfeeding.
So there you have it for our women. For our women out there, you can have a seizure or you can be on medication and you can still safely breastfeed if that's what you want to do. So, is Dr. Isabell, you started to say something? I'm sorry.
Yes, and I also do HIV. The newer medications, unlike for example, the Dilantin, which could the antiviral meds could affect the metabolism of the antiviral meds, the levels of the treatment, or it can lower the Dilantin level, or it can raise the Dilantin level. With these newer agents, you have less interactions of medications with the new seizure medications.
Yeah, we already talked about driving, but again, breakthrough seizures might be a consequence of not properly taking your medications. So if you have an epilepsy disorder and you've been prescribed medications, please don't miss them or stop taking them, because like Dr. Isabell said, if your levels drop, then you're likely to have what's called a breakthrough seizure. And if you take too much, you may have some other neurological complications and or body complications. Dr. Phillips, did you have something you wanted to say?
I just wanted to add on to what you were saying, 78, which is, anytime there's a significant change in your health, if you have a seizure disorder, you want to check in. Because again, there are a variety of things that can affect the drug levels. And if your drug levels are not appropriate, then that could unfortunately make you more likely and more susceptible to having a seizure. So again, one of the interesting, nuggets or factoids out there with respect to epilepsy is sometimes it can be associated with a shorter lifespan. But in looking at that shorter lifespan, it also was associated with not managing it well, not taking the medications as prescribed, maybe not staying on top of monitoring the drug levels, maybe not letting your doctor know that things have changed. I'm pregnant. I'm taking this new medication now. I'm in the hospital and I have an illness. All of these different scenarios can possibly affect your medication, thereby making you more at risk. And unfortunately, when you have a seizure, anything is game. You could fall, hit your head on the corner of a table, as they say in the Virgin Islands, party done.
Thank you, Dr. Phillips. So folks, you've heard it is so much complex things to think about as a physician or a healthcare provider when you're talking about seizure disorders. We don't know all there is to know about every seizure that's out there. There's so many different types of seizures. There's so many types of combinations of things we need to do. So we need more information to understand so that we can better treat seizures. And part of that process is going through what we call clinical trials. Clinical trials where we evaluate a medication to see if it will have the effect the desired effect we want to have in suppressing seizures or getting rid of seizures, and so forth and so on. There may be clinical trials on different types of modalities or implants or whatever. But the problem we have in our society is that we don't have enough people of color that are involved in our clinical trials. So, we need to get people to understand that, if you don't participate in a clinical trial, we don't know what's going on in our own community, because we don't have, we are our own unique type of people, and we might respond differently than, say, another type of people that are not of color. So we need to be involved in those studies, because more of us that are involved in these studies, the more we can figure out how it is best treated for our different society. So we have a special presentation tonight to that end. We want to talk about people getting involved, and a lot of people are fearful of getting involved in clinical trials, but I don't think you should be fearful, because they are a necessary thing that we have to do. And if there's a situation where you can't be involved in a clinical trial, then you won't be involved in it, but you can participate anyway. So Dr. Phillips has done a great job of team contacting him about getting people involved, talking about seizures. And I'm gonna digress at this time and let Dr. Phillips introduce our special guest tonight. Go ahead, Dr. Phillips.
So again, as Dr. Boykin just mentioned, one of the big things, even before we talk about seizures, is the reluctance and hesitancy that we as a community, and I say we, I mean African Americans, have when it comes to participating in medical research. And when we look at the conditions that affect us, if the research being done on the new treatments are not including individuals that look like us, how can we expect these treatments to be most effective for people like us? So understanding that, we understand that there needs to be more compassion, there needs to be more sensitivity. So we've been working with other entities to try to find, number one, identify good quality research for our communities to participate in, and then also making our communities aware of these opportunities. So we have Miss Sheila Thorne with us tonight. She is the president and CEO of Multicultural Healthcare Marketing Group, and it's an organization that is working on trying to improve the stigma that has prevented us or made us as a community more reluctant to participate in any research. And we know if we want to optimize the treatments that are available for our community when it comes to epilepsy, we need to be involved. So without any hesitation, no further ado, I'm going to introduce my sister, Miss Thorne. Welcome, Sheila. How you doing?
Thank you so much, Dr. Phillips, and what a privilege and an honor to be yet again with the 2nd District Health and Wellness Committee. And I appreciate the opportunity to talk about clinical research and people of color. And what you had said initially to introduce this webinar was outstanding. And clearly, I think this will be a wake-up call to many, not only of healthcare professionals, but others. But here are the facts, ladies and gentlemen. I've been doing this work in clinical research of Black, Latino, Asian, and Native American populations for about 30 years, working with Big Pharma, helping them to be culturally respectful, culturally competent, culturally proficient, and culturally respectful of our culture and where we've come from. And historically, the industry has not done a good job of reaching out to people of color in terms of encouraging them and educating them about clinical research. I have a virtual company since 2003. I came out of the medical advertising world. Mom was a nurse, sister was a nurse, so this stuff is in my DNA. So I totally understand why we have to come together as a people in order to be more educated and make informed decisions about our healthcare and clinical research in particular. But here are the facts. 578,000 African Americans have epilepsy or a seizure disorder. That's according to the Epilepsy Foundation. I had occasion last week of speaking to a 57-year-old African-American man who has had seizures for as long as he can remember. He was officially diagnosed at the age of 10, and he was having then 1 to 2 seizures a month. Then they went away. At least that's how he expressed it. They came back when he was in his 2nd year of college. And that started on the roll of having 2 seizures a month. It interrupted school. He had to drop out. He couldn't keep a job because he never knew when these seizures were going to happen. So his income was erratic, and that affected his family. He certainly had an opportunity to try to get good positions, but he couldn't find them. So at the end of the day, he went to a number of very prestigious healthcare organizations. And finally, they told him, we can't do anything for you. So he's been living with seizure disorders, and now at 57 has gotten himself acclimated to what triggers his seizures, where he has to go to get care, whether the medications work. And it went on and on. We talked for about 45 minutes. And that was a really eye-opener to me to see it's real. It's real. And we have to understand and be educated in order to learn. But clinical research is the foundation of evidence-based medicine, as you all have said. If you don't have good data, if you don't have the population that's going to be affected by this in the clinical trials, you're not really sure about side effects, about dosing, about all of the issues regarding quality healthcare. And so my task and my team's task, and we are all of color, half of us are multilingual, and that's all we do. We don't do advertising for dolls, cake mixes, and, fast food. We do healthcare, from prescription medicines to over-the-counter medicines. What does the end user need to know about their condition? Living with it, surviving with it, and where to go to get the quality care, especially if those folks who are going to be treating us don't look like us. And that obviously presents a barrier right from the jump. But we're in a new day now. And that's why I'm so excited about Omega Psi Phi interest and dedicating this webinar to this issue. You're the community leaders. You're the ones that are empowered to be the trusted messengers to deliver correct information within a cultural context. So I'm going to go very quickly through some slides I prepared for this evening to show you why this has been such a challenge for people of color in terms of volunteering for clinical research. I believe Brother Percy has my slides. I don't know if you can pull them up.
Brother Pierce, yeah, there you go.
Perfect, perfect. And please, I'll tell you when to go to the next slide. Increasing diversity has always been strongly encouraged by the Food and Drug Administration, who approves all of the drugs that we are currently using, both inline and pipeline. The challenge has been, it's only been encouraged, but a new day has dawned. Now it's no longer just a nice thing to do. Now it's a mandate from the FDA that you must have a proportionate number of people of color in order to do subgroup analyses to make sure that this drug, this intervention, this device is safe and effective in everyone. I have 2 nurses on my team. My CFO is a former auditor for the FDA with a specialty of medical devices. So we know the business of medicine. We are not clinicians, but we understand how to reach out and engage. So let me take you why this is a new day. Next slide, please. In 2020, March 11th, we'll never forget the year 2020, will we? That's when the World Health Organization declared COVID-19 a pandemic. My public health friends and colleagues that I work with, we started talking about that pandemic in the summer of 2019. We heard about this novel coronavirus that was devastating the population globally. And we knew by the time it made its way to the United States, it was going to decimate people of color, Black, Latino, Native Americans. And we were proven true, unfortunately. But then about 2.5 months later in that same year, an African-American man by the name of George Floyd was murdered by unethical, inhumane police in the streets of Minneapolis. And so that opened a Pandora's box of pervasive, persistent injustices and inequities in American society. It got a global response. The pharmaceutical companies put aside their shareholder concerns and market share and joined together. And in a record amount of time, produced a vaccine that saved thousands and thousands of lives. So therein lies the key to making sure that we galvanize the best and the brightest in research to tackle a problem. Imagine if we could do that for heart disease or for some cancers or for others, where we would be today. But it also illuminated the fact that there are issues with these populations that discourage them from going into clinical research. Next slide, please. So from that vantage point in 2020, we have to take a step back. The first time the government documented that there were racial and health care disparities was in 1985. So these disparities are not new. It's not unusual for people of color to be less served, less looked after, poor care, get sick faster, less screened. All of those things were there. And this was with uninsured people. So that Malone-Heckler report, Thomas Malone was a biostatistician for NIH. They looked at hospital records. They looked at charts. They looked at everything. And the conclusion was people of color get less than quality care in America. Interestingly enough, that report made it possible to launch the Federal Office of Minority Health and state offices of minority health. And so healthcare now became inclusive. But we haven't made a lot of progress since then. Next slide, please. Fast forward to the 2002, the Institute of Medicine, National Academy of Sciences landmark study, Unequal Treatment. Congress requested, and this was pushed by the National Medical Association, representing 50,000 physicians of African descent, to take a look at this. Why are these disparities existing? Best technological care in this country, the premier medical teaching institutions, among which you know are Morehouse, Meharry, Drew, and Howard, all of these things. Why are these groups still suffering more, getting treated less, and dying sooner? But this study was a little bit different. This was a study of insured African Americans. So you can no longer say poverty was the problem, okay? They had insurance. They were economically middle class, and they were still suffering from the same diseases. So this was quintessential. And notice the language, unequal treatment. That's civil rights language, unequal treatment. So we clearly are going now into the justice and equity arena of how we can eliminate these disparities. Next slide, please. But when we take a look at what we need, next slide, please. Hope that didn't get stuck. Okay, great. This still remains the pervasive factor, health from the Kaiser Family Foundation. Despite significant advances in civil rights, race remains a significant factor in determining whether an individual receives care, whether an individual receives high quality care, and in determining health outcomes. So we've got to be bold and courageous and make sure we speak truth to power. It makes a difference what you look like in this country when you go in to seek medical care. People make assumptions. They assume that you don't have money. They assume that you're poor. All those stereotypes that you brothers talked about kick in. And unfortunately, that has been persistent and pervasive. Next slide, please. But we know why this mistrust and distrust is so deep. And one of the featured most egregious examples of medical research gone bad was the Tuskegee syphilis experiment. Subtitle of it is Watching the Progression of Syphilis in the Adult Negro Male. So it purportedly started out to make these groups different. I had the occasion to speak to this author, James Jones, and if you haven't read this book, you should. He's a white investigative reporter that took this on to find out what was this Tuskegee all about. And we know what it was all about. The New York Times actually was one of the grandchildren of one of the Tuskegee members, was a whistleblower over this study, and it shut down. But it had gone on for 40 years. And that definitely impacted the mindset of those ignorant, illiterate farmers in Tuskegee, Alabama. But it's not just Tuskegee. That's a metaphor for bad medical research. There's more to it than that. Next slide, please. And if you haven't received this book, you need to pick it up and read it. Medical Apartheid by my dear sister, brilliant sister, Harriet Washington. She traced medical experimentation in Black Americans from colonial times to the present. So Tuskegee was a blip on the radar screen. A lot happened before it, and a lot of it continues today. So this book was definitely a bomb into the medical research community that we have to acknowledge that people know, they remember, and it makes them afraid of volunteering. Next slide. And this now, because of COVID and the rush to get people to volunteer for the COVID vaccine trials, unfortunately, this was the headline in the latter part of that year, 2020. I won't be used as a guinea pig for white folks. I don't want to be a lab rat. I don't want to be part of an experiment. But as many of you brothers said, there are various kinds of clinical trials. Not all of them are for pharmacological treatment or for drugs. There are some observational trials. There's a number of trials, but we don't know about them. We don't understand what their impact is. And we don't really appreciate the fact that if we're not in the trial, how can we expect quality care of the providers who have gone to school and been medically trained? So we want to make informed decisions. Next slide. This was a book that I found back in 1999 that was produced by, it was actually a booklet, National Pharmaceutical Council. I picked it up when I was attending a conference, and it intrigued me because this was produced by the National Medical Association along with the members of the MPC. And here's what they said. Pharmacogenetic research in the past few decades has uncovered significant differences among racial and ethnic categories in metabolism, clinical effectiveness, and side effect profiles of many clinically important drugs. Well, I was excited when I got this brochure, and I called MPC and I said, how many of these can I get to use as I speak to groups and community groups and healthcare professionals? The young lady in their library said, you can have all of them. Nobody ever asked for them. So that shows that there's a lack of understanding on the professional as well as the personal side about the increasing need to have diversity in clinical research. You can order it online and download it if you're interested in what it has to say and use it for educational purposes. Next slide. But I was encouraged, because when you look at the demographics of the country, these numbers about participation in clinical trials, and this is 2018 data, have been persistent. If there are 13.4% African Americans in this country, only 5% participate in clinical trials. Hispanic is even worse. Asians are not even on the radar screen, and Native Americans haven't even been thought of. So there's obviously a disproportionate problem that we've got to change. But look at what happened with COVID-19. Next slide. These are the results from the COVID-19 vaccine trials. 10.6% of Blacks participated. That's the highest I have ever seen in my experience. 11.6 Hispanic, 5.7 Asian, and obviously we've got a serious problem with our indigenous populations. So this means to me that it's possible. What did they do during the clinical trial of recruitment that we can learn from? They went on the ground. They went into barbershops and beauty salons and churches and bodegas. They met the people where they're at, face-to-face encounters, and that's what helped convince people to be a part of clinical research. So this clinical diversity, the diversity in clinical trials is not a dream. It's not elusive, but we've got to change the way we do things. This is a watershed moment. We've got to switch gears and try not to do the same thing over and over again if we expect a different result. So this tells me there's promise. And working with leading organizations that have the trusted ear of the community, like Omega Psi Phi, would be critical to opening those doors and educating your constituents and your members and all of those connected with you. So I'm encouraged. I'm not an optimist or a pessimist. I'm a realist. You know, do you have the money? Do you have the time to make it work? That's our charge. And we as a people need to take ownership of that. Next slide. Here is where the game really changed. On April 13th in 2020, Dr. Robert Califf, FDA commissioner, said that as the population becomes increasingly diverse, ensuring meaningful representation of racial and ethnic minorities in clinical trials is fundamental to public health. So it's now no longer a nice thing to do. It's now no longer just encouraged. It's a mandate. Those studies will be bounced back. Those drugs, those devices, those interventions will not be approved unless there's a proportionate number of people of color in clinical research to show this is safe and effective in everybody. That was 2022 last year. So we now have a different playing field, and we need to step up to the plate and make sure our members, our constituents, our families, our communities are educated. Next slide. So achieving diversity is a key focus throughout the FDA to facilitate the development of better treatments. And quite frankly, if you can help those that are sick the most, doesn't that help everybody? So clearly you need to start with the vulnerable groups who are disproportionately impacted and help fight disease, whether it's a cure, whether it's a treatment. And most of the websites of pharmaceutical companies I've read say, we're here to improve the quality and longevity of life of all Americans. But if you're not in it, who is that all Americans you're talking about? Okay, so we've got to make sure that we demand our place at the table, have the resources and the ability to spread the word about the critical importance of clinical research. Next slide. And these clinical trials, as I said in the beginning, really make healthcare professionals confident that what they're prescribing is not extrapolating data from white middle-aged men, as they've done for so many years, but really focused on the issues of this group. I'm working now on 3 clinical trials with my team, one on osteoarthritis, one on lupus, and another on epilepsy. And that's what brought me to Omega Psi Phi, this clinical research on epilepsy that is showing very promising results in terms of getting people of color. And they're very keen about doing that. I work with Neurona Therapeutics, which is the company that has the protocol for this clinical trial. And I know you had the pleasure of meeting some of the members, or one of the members that came to the Pittsburgh conference, as well as on a Zoom meeting that we had a couple of weeks ago. So it's a new day. And we have to, again, step in that spot and don't wait for it to be done for us. Demand that it be done with us. Next slide. And interestingly enough, something appeared in the literature, because on my team we read JAMA, New England Journal, and all the medical books, and the pulse oximeters were denoted during being used, obviously because of oxygen saturation during COVID, and they discovered that people with melanin, people with dark skin, the readings were not accurate. So those devices didn't work in people of color, people of darker complexions. They would not have known that, or they would have known that, I should say, if people of color had been in the clinical trials for this device. They were not. So that's dangerous. So you're sent home thinking you have a proper level of oxygen saturation, and you don't. And some people of color, Blacks in particular, died because that diagnosis wasn't accurate. So this is serious stuff, folks. This is not just something that the pharmaceutical companies are trying to make a new buck. This is life and death. The sister on the right is part of a team that is developing a new oximeter that will be more accurately used for people with melanin. So stay tuned on the results of that. But that's one example of how we can be hurt by not being in clinical research. Next slide. And then there's a brother in Nigeria, a medical student, who all of a sudden said, how come all the pictures in medical books are white folks? You know, how are dermatologists, how are other docs to see how disease presents? So he's on a mission. He's also an artist. So he's redesigning some of the illustrations in medical books so that whoever is studying this, they'll see that everybody doesn't look the same. How does this disease present in people with dark skin? How would you know whether a rash is red on somebody with my complexion? How would you know how it affects my skin? So this is another simultaneous movement that's going on, and he's making a big difference. So stay tuned for him as well. Next slide. And the barriers to participating are, I'm sorry, go back one. I'm sorry. Okay, thank you. The barriers to volunteering, if you feel like you want to and can and should be in a trial: transportation, costs for childcare, costs for elder care, how many visits, how is it going to affect my job, how is it going to affect my life, how much time is it going to take, what are the constraints, what are the requirements, and all of these now are being put into plans for clinical research. So there may be medication for the study covered free. There's a stipend for travel, and not necessarily reimbursement, but giving you the money in advance so that you don't have to lay it out and wait to get your money back in 30 days, because that doesn't work with community folk, okay, who are living paycheck to paycheck. So there are major changes being made to put into the protocol. What about the inclusion-exclusion criteria? We know it has to be very tight because we want the outcomes to be clean, but does it have to be as stringent as something they're asking for? So IRBs are taking a look at that. And so if you lessen some of those restraints or those commitments, does that impact the quality of the research? So these are conversations that are being had. But my concern is we're not at the table having them. And we need to make sure that we insert physicians like yourself across all therapeutic categories to talk about your lived experience with your patients, the patient voice, and how this clinical study will affect them. So that's the world of social determinants. Pharmaceutical companies have the resources. It's a question of how it's allocated. Next slide. So partnerships, allies, are what I look for before I step foot in the community and ask that they consider volunteering for clinical research. And Omega Psi Phi, with your legacy historically, globally, networks, your physicians who speak so eloquently and correctly on this webinar, that's who we need at the table. So the first line is what you did tonight: education. What is epilepsy? What are the symptoms? How do you get it? Who treats it? People don't know that your emergency room visit, hopefully, if there's an issue, might lead to a neurologist, or it might not. So we've got to make sure that we are all along the continuum of patient advocacy, but to start with the right partner and to invest in you. I tell my clients, this is not a cost to partner with Omega Psi Phi. This is an investment. How serious are you about increasing diversity? What resources can you give this organization to use their network, their resources to educate people? We're not telling people to volunteer. We're saying, here's what it is. Here's what it means. Let's talk about it. Go to your provider. Have this conversation. Make sure that this clinical trial, whatever it might be, is appropriate for you. Bring your family in. Bring a pastor in. Bring your trusted advisors. Help the community take charge and control and be empowered. I don't know whether it's on this particular, the next slide, but my team pulled together a video. I'm going to share it with you. It's only about 9 minutes because we found that there was no education about clinical research in the community, and we needed to start the conversation. I wrote the script. These are Black actors. The team that produced it, these are brothers that work for Good Morning America. So everybody connected with this video is Black. So hopefully you'll enjoy it.
Ms. Stone, we may run out of time because we're kind of getting to the end of our thing. We may not be able to do it because we only have like a couple minutes left.
All right, well, let's skip it then. I can send it to Dr. Phillips to share with the group because I love your feedback and your input. We did 3 videos. One with a couple, a wife that was considering being in a breast cancer trial, the next working with the clinical team, and the third, the outcome. So at the end of the day, all the forms of inequality and injustice in America are bad. But of all of them, health is the most shocking and the most inhuman because it often results in physical death. So clearly there's a clinical imperative, there's a research imperative, but for our people, there's a moral imperative. If we want to close the gap in terms of racial and health ethnic disparities, we've got to be at the table. And if there's no chair for you at the table, I will work with you to pull in a folding chair. So we put in front of these companies what we require to receive quality health as all Americans. Thank you for your time.
Thank you so much, Ms. Thorne. It was a pleasure to have you speak to us tonight. And as I said, I want to make one quick comment because during the COVID crisis, Dr. Phillips and myself, we were on a team of educating Black folks about COVID and how it affected Black people. So it doesn't surprise me because when I looked at the studies and I knew that 10% of only 10% of people were involved in the clinical trials for these vaccines, it doesn't surprise me that the vaccines were not embraced by the Black community initially.
Exactly.
But that was part of my job to say, this is what we have. We have 10% of Black people involved in these studies. What if we had more? Right. I think attitudes would change about the outcome of COVID and these vaccines. You would be afraid of them. The biggest thing we had to deal with was talking about COVID. Talking about Tuskegee and things like that. So this is what we want to focus on. People need to get involved in these clinical trials. So I thank you so much for being here tonight. And I'm going to turn it over to Dr. Phillips to give a few closing remarks, and we're going to have to get out of here, guys. So.
Thank you.
Sheila, thank you so much for your information. I think your passion and your just your expertise in this area and your investment in this area is really well felt. And I think, what you're saying, as far as partners coming together that are invested in supporting our community, not only you and I, but there are other entities in the community that need to link together so that we can not make us, as I said during our pandemic talks, the low-hanging fruit.
There you go.
And it's not low-hanging fruit in a good way. It's low-hanging fruit in a bad way. Exactly. Again, in line with our monthly message as far as prevention and understanding not only the conditions, but what to do with the conditions if you find yourself in that circumstance, and how to do work that can help someone down the road as far as them being able to make someone else's life a better situation than their own. So I thank everybody for their attention. I thank my brothers, Dr. Isabell, Dr. Plummer, for their expertise and their time, and our new moderator who has stepped up tremendously, Dr. Boykin. Thank you very much. And I must say, my brothers, I'm mad that I didn't get time to put my bow tie on because y'all bow ties will start. But Sheila, thank you so much. Mm-hmm. And again, your beauty is everything looks tremendous. So I thank all of this Black excellence that we have on here, and let's keep it going.
About nothing without us, nothing about us without us.
That's correct.
So that's where we got to go. And thank you all for your passion. And let's spread the word about this Neurona clinical trial on epilepsy of seizures starting in the temporal lobe. That's who we're looking for. So it's just begun.
All right, thank you so much. But brothers, I'm going to go ahead and take us out. So, Brother Pierce, if you go ahead and I'll give the close out, if you will, at this particular time. For Piercy. All right, thank you. So, thank you so much for being here tonight. We especially thank Ms. Thorne for being here with us to talk about clinical trials involving the Black population and people of color. We need to be more involved in these trials because we can't complain about the outcomes if we don't get involved to see how they affect our community. So we want to thank you for being here. I want to give a special thank you to our 2nd District Representative, Dr. Rico Gales, for letting us carry on these conversations. I want to thank our guests and our families for being here. And I especially want to thank our brothers for taking the time out of their evenings to come and talk to us and give their information about how we do things and how we prevent medicine. clinical trials, believe it or not, can be a part of preventative care. So with that, have a good evening, and we'll see you next month.